It's a great pleasure to see you all here this evening. A lot of new faces at this NYU Abu Dhabi Institute event, which I'm delighted to say is being co-convened with the Cleveland Clinic. And this indeed marks a sort of inauguration of a series that we hope will continue perhaps through this year, but certainly into next year. And very grateful to our colleagues at the Cleveland Clinic, in particular Dr. Robert Lorenz for making this possible. It's a great pleasure and honor indeed to be able to introduce our two guests this evening, both distinguished members of the Langone NYU Medical Center, as well as, of course, Cleveland Clinic, the CEO, Dr. Delos Cosgrove. I will, in fact, introduce our guests very briefly, even though I could go on all day, given their CVs, because both our guests have to catch planes from Dubai tonight, and you'll see them exiting sharply presently after the talk. Dr. Delos Cosgrove is the president and CEO of the Cleveland Clinic in Ohio. He also provides over a multi-billion-dollar healthcare system comprised of that Cleveland Clinic and a further 9 community hospitals, 50 family health and ambulatory surgery centers, the Cleveland Clinic Florida, the Lou Ruo Center for Brain Health in Las Vegas, in Nevada, the Cleveland Clinic Toronto, and the Cleveland Clinic Abu Dhabi. He has a medical degree from the University of Virginia School of Medicine in Charlottesville and completed his clinical training at Massachusetts General Hospital, at the Boston's Children's Hospital and Brook General Hospital in London. Joining Cleveland Clinic in 1975, Dr. Cosgrove was named chairman of the Department of Thoracic and Cardiovascular Surgery in 1989. Under his leadership, the Cleveland Clinic's heart program was ranked #1 in America for 10 years in a row. He has performed an astonishing more than 20,000 operations and earned an international reputation for expertise in all areas of cardiac surgery, especially valve repair. He's also a frequent speaker on the international scene. At various fora, he's spoken to the World Economic Forum annual meeting at Davos, Switzerland, and the Senate Health, Education, Labor, and Pensions Committees in Washington. He's featured in national magazines and newspapers, including a cover story in Time and major articles in Newsweek, the New York Times, the Washington Post, and many others. And he's a frequent appear on several of the media outlets, including the Charlie Rose Show on PBS. First to speak this evening will be Mr. Andrew Rubin, Vice President for Medical Center Clinical Affairs and Affiliates for NYU Langone Medical Center, as I said. For the past 10 years, Mr. Rubin has served as Vice President for that center. Formerly, he was the youngest dean at the NYU School of Medicine. He is an expert on the business of healthcare, from the controversial national debate over healthcare reform to the use of electronic medical records. He has a weekly Sirius satellite/XM radio show entitled Healthcare Connect, during which he helps his audience navigate and understand complex healthcare/health insurance industry issues. He sheds light on all aspects of the healthcare delivery system and industry, and is a frequent guest on NBC's Today Show, CNN, Fox News Channel, and several indicated talk shows. It's a great pleasure and honor to have both guests here today. Please welcome them.
Well, it's certainly a pleasure to be here. I talk about healthcare reform in a lot of places, and this is unquestionably the farthest I've ever traveled to talk about healthcare in the United States, and it is really exciting for me to be here. We have an exceptionally big challenge tonight. One, with this CV like Dr. Cosgrove's, very different than mine. That's challenge #1 for me. Challenge #2 is healthcare in general, and specifically healthcare reform. We could talk about it for hours and hours on end, but I have about 20 minutes. So I'm going to do the best I can to lay out some very complicated and complex theories and thoughts about healthcare in the United States. I'm going to talk a little bit about what's happening here in the UAE, Abu Dhabi, Dubai. I've had the pleasure of meeting with some people today who work in healthcare in the United Arab Emirates, and it was interesting to me because the differing perspectives on healthcare here, it's not that different than the United States. Some of the challenges they're facing and the different perspectives they have, and how people in the United States that have the same differing perspectives. So if anyone who knows anything about healthcare in this part of the world, Abu Dhabi, the UAE, has a fairly extensive multi-year plan to be a global leader in healthcare. Whether or not they can get there, who knows? But from what I've seen happening in this region, nothing would surprise me, and certainly partnering with the Cleveland Clinic is a great way to get started. In terms of concept of delivery of healthcare, while there is some private money in healthcare here, it really is a government-run system. And to get there, they're going to be developing global partnerships with lots of institutions, whether it be NYU, Cleveland Clinic, Johns Hopkins, to run some of their programs. That's what their plans are. So how does the UAE compare with us in the United States? They spend about federal dollars. Now, again, statistics aren't always that easy to come by in this region. But the World Health Organization says about $5.5 billion in the UAE as compared with $2.1 trillion in the United States. I've heard extremely widely different opinions on how many people actually live here, between 4 million and 8 million, as compared with 300 million in the United States. There are, in fact, 19 beds per 10,000 people versus 31, and there's clearly a lot more physicians in the United States. And UAE spends about $1,200, and I know it's different based on whether it's Abu Dhabi, Dubai, the other Emirates, but they spend about $1,200 on every person living in the country on healthcare that they sponsor, and the U.S. spends about $7,200. But here's the amazing thing. I was actually really surprised when I saw this. We don't actually live any longer in the United States if you look at statistics. Now, sure, there are lots of reasons for that. I could talk about them all day long, but the fact remains, we really don't. About 78 years old is the life expectancy in both countries. Now I want to shift gears, because this is really what I like to talk about, and what's going on back in the United States. You know, in the US, we have a very strong opinion on what we want from our healthcare system. We don't really have a strong understanding of how it works unless we get sick, and then we're sort of confused even within that system. So, you know, the American way is to want and demand what we want when we want it, particularly in healthcare. Yet there's this tremendous disconnect between what we actually pay for our healthcare and what it costs the system, society. And that disconnect makes it even more complicated for the average person to understand it. So think about it. You get sick, you want everything, and you want it right away, and you don't care what it costs because you're only paying a $10 copay, or your insurance picks up the rest, or your employer's picking up a big chunk of the healthcare insurance. And probably one of the biggest flaws in our current healthcare system is that we're a very, very treatment-oriented system. We don't do enough in primary care. We don't do enough to keep people out of the hospital. And there's, again, lots of reasons for that, which I'm not going to get into. But we tend to respond to a crisis as it presents itself, and our provider system is oriented to pay people to do more. So we have this healthcare reform challenge over the past few years. It was signed into law about a year ago in March. There was supposed to be a whole big fanfare about the one-year passing of healthcare reform in the country, and yet it was overshadowed by a lot of other news, the Japan earthquake and other events, so it kind of got buried and there wasn't a lot of talk. But what's interesting in the past year, and even really before healthcare reform passed, there is a tremendous amount of conflict within the healthcare system with all the people in healthcare over whether or not healthcare reform is actually good. So if you talk to a doctor, if you talk to a hospital CEO, an administrator like myself, a pharmaceutical executive, a device manufacturer, anyone who works in the healthcare system in the United States, we would all say it's broken. We would all say it doesn't work. Yet we would all have differing opinions on how we want to fix it. And it's not that we don't all want to work together. It's that it's so big and it's so complex, and we all have sort of an interest in maintaining the status quo because we don't understand what it's actually going to look like in the future. So imagine trying to work together to implement something where you don't know what the outcome's going to be, and you don't know if you're going to have any money to keep your operations running, and you don't know if you're going to have enough money to pay your doctors, and you don't know if there's going to be enough R&D money to invest in the next generation or technology or chemotherapy agent, for cancer. It's really, really scary. And How are our doctors going to get paid? How are our hospitals going to get paid? So what we'll say is, well, we want to do better. But unless you can tell me how it's going to work and show me how it's going to work, or let me participate in the conversation of how it's going to work, we're all going to run away from it. Because we're not going to say we're going to run away from it, but we're all going to wait for something to happen, or we're going to fight about how we're going to get there, and nothing's ever going to get done. And then, as you know, I showed you that slide, the trillions of, this is a, healthcare reform is a, you know, a $1.1 trillion, 2,000-page law. You can imagine how hard it must be to implement something like that, particularly when most of the people implementing it don't understand it themselves yet, because the rules haven't been written. And the people who are writing the rules don't exactly know what the rules are supposed to be. It's a real mess. This is probably my favorite, my favorite slide, and I don't normally use note cards, but I think this one is too important. So our politicians in the country have really managed to mess this one up. Now, you could say they do that a lot in the United States, but you know, it is what it is. There is such fighting between the liberals, the Democrats, and the conservatives, the Republicans, over healthcare reform. They don't understand the first thing about what it is. If you actually talk to any legislator, Republican or Democrat, so few of them actually understand the healthcare system, but it doesn't matter because they're just fighting over it. To them, it's about being elected. It's not really about healthcare. And again, this isn't to disparage our politicians because they actually, like our doctors and hospitals and administrators and healthcare executives, want to do better for the country. But again, it's so confusing and so difficult for them to understand. They just focus on, am I going to be in office? And we're losing something in the translation about what it really means to reform the healthcare system. And the elections we had last November in the United States, they were the midterms, where the Republican Party was swept back into power in our House of Representatives, really reflected that. It was, by most accounts, the #1 issue. Over jobs, healthcare reform or repealing healthcare reform took more priority and had more exposure in the elections, if you listen to exit polling, than job creation did at the time. So my favorite bullet on this slide. So we all talk about, we listen to on television news programs, and I've debated with many of them, repealing healthcare reform. We got to start over. We got to do this differently. We got to come up with a new plan, something different. And then you ask the people what to do, whomever it is, Republican or Democrat, and they don't have a plan because they don't. It's so complicated. They don't have an alternative to it other than to bash what was passed. And I don't know how much this got picked up in the local news here, but there was a big bill, I don't know if it was a bill, something presented to restructure the Medicare program in the United States by the House Budget Committee chairman. And his whole plan was to privatize Medicare because the Republicans believe the government shouldn't be in the business of health care. Yet the entire bill was talking about how the government was going to regulate the privatization of the Medicare program. So it was, in fact, just shifting the administration of the public government-run healthcare program for the senior citizens over to the private sector, with Congress and Washington still actually running the program. You can imagine how confusing it is for everybody to understand. So there's a big challenge here, a really big challenge. And I talk about this a lot. Does society really have the willingness to actually ask the deep and meaningful questions that we all need to ask ourselves about what we want our healthcare system to be? America's a democracy. Our politicians are elected, and we all want healthcare. We all understand that. But do we really understand the kinds of questions that we're talking about? Does the government have a responsibility to provide unlimited healthcare with unlimited resources to everybody, or are there actual limitations to what we can afford to do? And if such limitations exist, rationing, if you want to call it that, who decides what it is? And can you actually have a meaningful conversation to these discussions, particularly when there's no right answer? So what's right for me, or what I believe is the right thing to do in healthcare, and I'm going to give you some real examples in a minute, may be completely different than what everybody in this room thinks. So then how do you actually implement something if everybody has a different opinion on what it should be? And then you hit an obstacle at every turn. Every time you think you've solved the problem, you've actually created another problem for somebody else. So if I say we're not going to do this, and everybody agrees with me, and we're not going to do this, somebody else is going to say, well, what about this? And again, I'm going to give you some examples and try and make this real for you. This is the first example. And I'm not a doctor, but this drug is written about all the time. And I actually have a very dear friend who is taking this drug right now for a brain tumor who's 52 years old. It is a wonder drug, no question about it. It, on average, costs about $100,000 a year to treat people with cancer, different types of cancers. And it's been referred to as the IT drug. It's about $3.5 billion a year in worldwide sales. $2.3 billion of them are in the US. And I think I mentioned this, at about $100,000 a year. And in most cases, they will tell you that the drug works to prolong life with people who don't take the drug anywhere between 4 and 6 months, and that's an average. It depends on the cancer that you have. So as an example, what is the value of life with this drug? Is it worth $100,000 a year? A new drug just came out 2 weeks ago, got FDA approval for late-stage prostate cancer. It's about $30,000 for 3 treatments, so $90,000, and it extends people's lives with late-stage prostate cancer for about 4 months. Now, I'm not telling you that's a good thing or a bad thing. I'm just telling you that each day we're going to have new drugs like Avastin that are going to be coming out, and Medicare is going to be asked to pay for it, and then the private insurance companies are going to follow suit. And each generation and new class of drugs we come out with is going to be more expensive, targeting an even more narrow disease condition. And we can't afford it, but we all want it. And if I had late-stage prostate cancer, I'd probably want it too. It's a tremendous challenge. About a month ago, maybe 6 weeks ago, in the United States, a study from the Food and Drug Administration, they don't approve reimbursement for whether or not Medicare will cover drugs cost. But they do regulate whether or not it's safe and effective. So they came out with a study that said Avastin did not work in women with late-stage breast cancer. They had the data. It does not work. Okay. I'm not a doctor, nor am I a scientist, but I believe that the FDA, if they say it doesn't work, it doesn't work. And they have the data to back it up. And it wouldn't surprise me that it actually doesn't work, knowing what I know about this drug. So the next day, one of the Medicare, I don't want to get too technical, but the way Medicare pays its claims for insurance in the United States, they break it out by region, so they're called intermediaries, and they're basically claims processing companies that have contracts with the government to pay Medicare claims. One of the regions that processes insurance claims in Southern California decided they were going to not cover Avastin for women with late-stage breast cancer. And I thought that made sense, right? It doesn't work. $100,000 a year, it doesn't work. Well, guess what? There was such a public outcry over this, the decision was overturned the next day. And again, they're looking at the study to determine whether or not they're going to do more studies, and probably in 5 years we'll come back with the same information that it doesn't work. Or maybe we'll find out it does work. Who knows? Interesting challenge. So, do we stop? Going back to what I was talking about before, I was talking about Avastin. Do we stop the reimbursement? Is someone going to look at the benefits and create criteria for it? Great Britain did that. They have the National Institute of Clinical Excellence. It's a totally different system than the United States, but they actually have an organization that looks at data, and they try and make these difficult decisions. And when they make a bad one, even though they have the authority to make them and say, we're not going to pay for this with the National Health Service, they still walk into difficult problems, and the public goes crazy. So depending on what the disease is, it's a big challenge. Washington State in the United States is looking at this now. I think you're going to see a lot more of this in the future because we really have no choice. Another big one, end-of-life care in the United States. It is very, very expensive, and I'm going to show you in a second. But we don't really live any longer. I showed you that earlier, and I actually have a slide coming up that's going to actually give you come back to the different ages. But we spend more money, 30% of the Medicare budget is spent on end-of-life care. That's $153 billion in the United States is spent on end-of-life care, which is defined as someone's life in the last few months that they're around. In the last 30 days, 80% of that $153 billion is spent. And as I showed you earlier, we don't live any longer actually doing that. Because our healthcare system is incented to pay for treatment, we get the doctors, hospitals, you all get paid by the more that we do, we are incented to actually keep perpetuating this problem. And because the public has this perception that they want to do everything they can to keep going, regardless of the cost, because we have that cost disconnect on what we actually pay for it, it's a problem that's almost too difficult to challenge, to tackle. And then you hear about this thing called death panels in the United States. So during healthcare reform, because it's so difficult to tackle this problem, and we spend so much money on it without any good outcome for it in the United States, the legislation as it was being crafted, there was an idea that said, we will pay doctors more money during a visit with their patients if they simply have a conversation with their patients specifically on end-of-life care. That was it. And that, hence, was the birth of the death panels. So a doctor simply having a conversation, taking time out of their schedule, because these are usually primary care providers who don't make a ton of money, spending time, a little bit of time, talking about, is it really worth all this money to keep you hooked up to tubes, to keep you going no matter what, turned into the death panel, and they was stripped out of the legislation. Pieces of it were put back in a different way, but nevertheless, that was how death panels were born. And you could see how difficult it was to get past the death panels with the American public to actually talk about healthcare reform. And again, you could see, with all that money we're spending, we don't actually live any longer. So listen, in 20 minutes, there are no right answers to anything I'm talking about. I think the point of what I'm trying to do here today, the point of what I try and do when I go on TV or if I talk about it on my radio show, is if I can connect with 5 people in the room who could then connect with their neighbors when they say, I'm against healthcare reform or I'm for healthcare reform, and you could actually explain to them what it's about and why we're doing it. Healthcare reform, healthcare insurance reform, whatever you want to call it. Just to start the conversation and get people engaged in healthcare so that they better understand the issues that we're facing will go a long way in starting the process of defining what it is we want so that we can actually try and implement something. Right now, the economy, U.S. economy, 17.5% of the economy is spent on healthcare. $17.50 of every dollar in the United States is spent on healthcare. By the year 2020, that's supposed to go up to about 20 cents of every dollar. And all the stats will tell you, this is not a political comment, all the stats, that was going to happen with or without healthcare reform. And we all know that's an unsustainable number. It's just, we'd have to stop funding schools, roads, bridges, whatever it is, defense, you name it. We cannot afford that. We have to start somewhere. And I think that this, or these kinds of forums, and what NYU Abu Dhabi is trying to do by educating people and bringing these messages out to the public is really the first step. The good news is, it's not all doom and gloom, because Dr. Cosgrove has the benefit of working for an extremely well-integrated competitor. They're in the Midwest and we're in New York healthcare system. And I believe he's going to come up and talk to you about some of the things they're doing to actually try and implement healthcare reform without healthcare reform itself. Just started.
Well, thank you, Andrew, and thank you all very much for being here. I'm delighted to have an opportunity to talk to you. We are here in Abu Dhabi, delighted to have the opportunity to be here. And I thought it'd probably be worthwhile to tell you a little bit about what the Cleveland Clinic actually is and our background and what we're trying to do here. And so I might start with a little bit of history of the Cleveland Clinic and how we put the organization together. And it does have sound.
Reflected the founder's belief in cooperative medical practice, research, and education, with space dedicated to each activity. The success was immediate. Over the next several years, a new 240-bed hospital and research annex were built. Founder George Kreil led the way. He was a skilled surgeon and outspoken public figure. An honorary member of the Royal College of Surgeons of England, he had an international patient following. In the 1950s, heart care became a major medical focus. Cleveland Clinic cardiologist F. Mason Soanes discovered a new way of imaging the coronary arteries. Coronary angiography pinpointed blockages and confirmed that heart attacks were caused by coronary occlusion. This discovery led to a second breakthrough. In 1967, a young clinic surgeon named René Favellaro performed the world's first coronary artery bypass procedure. These synergistic discoveries launched the modern era of heart care worldwide. The clinic grew rapidly in the 70s and 80s. To help manage its growing complexity, the clinic instituted annual professional reviews for all staff physicians. This commitment to measuring performance distinguished them academically from all others, and the data set standard practices. Cleveland Clinic built 15 family health and surgery centers in surrounding communities. Through mergers, it acquired a system of 9 community hospitals. In 2002, the clinic founded the first new medical school program in the U.S. in 25 years. The Cleveland Clinic Lerner College of Medicine, now tuition-free, uses a unique curriculum specifically designed to graduate a new generation of physicians skilled in both scientific research and the practice of medicine. Today, Cleveland Clinic has grown to 37,000 employees. With 1,800 physicians and scientists in 120 medical specialties and subspecialties. It is the second largest group practice in the world, with facilities extending well beyond Cleveland, Ohio. Cleveland Clinic, Florida includes an integrated hospital and clinic in Weston. The clinic also has health and wellness centers in West Palm Beach, Florida, and Toronto, Canada. The Lou Ruvo Center for Brain Health in Las Vegas is specially designed to advance the research, early detection, and treatment of neurocognitive disorders. Internationally, Cleveland Clinic partnered with Mubadala Healthcare to build a full-service hospital and a specialty clinic. It also manages Abu Dhabi's Sheikh Khalifa Medical City. The clinic's footprint is becoming increasingly global, with eCleveland Clinic and the transmission of electronic medical records. A new era began in the fall of 2008 with the opening of the Siddell and Arnold Miller Family Pavilion and Glickman Tower at Cleveland Clinic. These two buildings house the Miller Family Heart and Vascular Institute and Glickman Urological and Kidney Institute. Together, they add more than 1 million square feet to the Cleveland Clinic campus and help meet the demand of an aging population for these services. The next frontier is patient experience. Over the past 2 years, the clinic has reorganized medical services into patient-centered institutes. Each institute combines clinical services addressing a single disease or organ system. For example, the Neurological Institute unites neurology, neurological surgery, and psychiatry under one roof. This integrated model of care is supported by a culture where engaged employees provide an exceptional experience for patients and families.
As I look back, I see this incredible dedication of the people who started this place and the obligation that we have to pick the torch up and run with it. This is a big responsibility. And you add that responsibility to the responsibility we have for looking after people. Everybody who walks into the hospital is terrified and needs to be taken care of in a personal way. We're all going to be patients, and we want them taken care of like we'd like to be taken care of. It's all about patients. And I think that's the centerpiece. And from that, you get a sense of the privilege of looking after people and the responsibility that goes with that.
Let me just say that the Cleveland Clinic started in 1921. This is our 90th anniversary in this small building in Euclid Avenue in Cleveland, organized by these 4 gentlemen who came together with a tripartite mission of research, education, and clinical care. The organization is quite unlike many organizations around the United States. We're a not-for-profit organization. We're a group practice, which means that we're not employed by a hospital, but in fact, we are a group of doctors who've come together to bring facilities together. So we have a stake in the success in the organization of that particular enterprise. We have physician leadership. Our CEO is a physician. We are all salaried, and we have no financial incentives. So I have a salary each year, and that's my salary for the year. And it didn't make any difference as a heart surgeon whether I did 2 or 4 heart operations. At the end of the day, I got paid the same amount. That's important because it removes the impetus, the financial impetus, to do more procedures, order more tests, etc. And it's one of the reasons that we have been identified as one of the high quality, low cost organizations in the United States. We have an annual professional review where we take very seriously you're peer reviewed. And last year we spent 8,000 man hours at that annual professional review with feedback directly to the individual involved. And we all have 1-year contracts. There's no tenure. I know that'll be tough at NYU, but nonetheless, we don't have any tenure. We think that's a good thing for us. Our staff is growing. When I joined the faculty in 1975, there were 140 of us. Now there are almost 3,000 physicians. The number of employees has gradually increased to almost 40,000 across the world. And we're organized a little differently. Most organizations are organized around physicians, whether you're in the Department of Surgery or the Department of Medicine. And we said there must be a better way to do that in order to organize not around physicians, but around patients and patients' needs. So we have completely reorganized ourselves. We have no Department of Surgery or Department of Medicine anymore. We have institutes. And the institutes are built around the patient's organ system that's involved, and heart and vascular, urologic, neurologic, etc., or a disease system like cancer. There's single leadership of that group and a common location. In the Heart and Vascular Institute, there'll be cardiac surgery, cardiology, vascular surgery, and vascular medicine, and they're all housed within the Miller Pavilion, which has cath labs, operating rooms, intensive care units, patients' rooms, and doctors' offices, all in one location. These are the list of clinical institutes. There are 18 of these, and these are the list of special expertise institutes, such as anesthesia and education, imaging, etc., which run across the entire organization. Now, we think that it's important for patients to get to the right type of facility at the right time for the right type of care. And so we have a series of steps as you go through the progressively ill patient. We have teamed up with Minute Clinic to have outpatient facilities where you can go and get your throat swab or your flu shots. We have 17 family health centers, which we continue to add to the number. We have 9 community hospitals, and those hospitals are developing centers of excellence and concentration. And we're adding 3 more outpatient facilities. This is our main campus. It's become a very unusual facility. It is the highest average severity of any hospital in the country. We have about a third of our hospital beds are intensive care units. We do not do obstetrics or psychiatry on that campus. In fact, have moved them to out to the periphery where children are born. And we transfer patients in for high technical care. We have a facility in Florida, which is a 150-bed facility with 180 doctors, and a facility that you saw in Toronto, Canada. This is not the wreck of a 747. This is Frank Gehry's architecture here, and this is the Lou Ruvo Center for Brain Health in Las Vegas. As you know, you're all familiar with Sheikh Khalifa and soon to be Cleveland Clinic Abu Dhabi. All these facilities are held together with connective tissue, which connects all of our 6 million patients, the family health centers, community hospitals, and the main campus through the electronic medical record with Epic. So you can move from one to the other seamlessly with your records and your x-rays and your lab studies. We're recognized for that by President Obama and as one of the outstanding electronic medical record systems in the country. The second piece of connective tissue that holds us all together is the transportation system. Mark Harrison, who's just becoming the CEO of the Cleveland Clinic Abu Dhabi. And Mark, you want to stand up so they recognize you? He's been a long timer here. He's been here almost 24 hours now. So he is just taking over. He was previously Chief of Medical Operations at the Cleveland Clinic. This is a transportation system that involves 3 helicopters, 2 fixed-wing aircraft, and a number of trucks to move patients. Last year, we had 14,000 hospital transfers moved from hospital to hospital to get patients to the right location. We've also kept track of, used dashboards to help organize our facilities and keep people apprised of what's going on and the quality metrics. As you can see, this is our core measures for appropriateness of care, and this is regularly updated, as well as things like occupancy, blood use, etc. These are some of our business intelligence dashboards that we have put together. Again, Mark is responsible for having originated these. You might note at the very end of this is a short cycle. This gives you up-to-the-date information about patients as particular problems arise, so you can address them in real time and enhance the quality of care that way. We put a great deal of emphasis into education. We have education for our physicians and a number of things that we have done to have our physicians keep up to date, particularly with things like leadership and career promotion. We think this is an important part of both developing leadership and for an organization which is physician-run. Now, we also do not think that all hospitals should be all things to all people. And you need to have centers of excellence. And let me give you an example of the centers of excellence and why we have developed those. We recognize that birth rate in Cuyahoga County, where we are in northern Ohio, has had a decreasing birth rate of 30% over the last 20 years. As a result, we have a number of obstetrical units that do not have adequate volume to measure up to the 1,500 minimum standard that is recommended by the American College of Obstetricians and Gynecologists. So we had a number of obstetrical services, some 5, and the first thing we did is we were doing about 900 deliveries a year at the Cleveland Clinic, and we moved that out to the community. We then had a number of facilities, Marymount in particular, a Catholic hospital, which was doing only 2 deliveries a day, or about 700, and we've merged that now, and we continue to look at hospitals which do not have major volume of obstetrics. I don't think any of you would want your wife having their child at some place that was not doing it on a regular basis. Similarly, heart surgery at some of our hospitals has diminished over time. This is Lakewood Hospital, and we merged that facility. So we've gone from 4 facilities to 3 facilities, essentially establishing cardiac surgery only in places which had a significant volume of work so that the team could continue their level of expertise. Now, we asked ourselves a question a number of years ago, why are we all here? It seems like a fairly obvious question. But you began to realize when you ask that question that whether you're sweeping the floor or unloading trucks or moving patients or a doctor or a nurse or an educator or a scientist or a clinician, you're only there for patients. And that is the one uniting factor that we have as a group. So we adopted as our mantra, patients first. And that cuts across everybody who works in a facility. The only reason we have a clinic, a hospital, facilities, or jobs is because of patients. The next thing we did is we established 4 cornerstones: quality, innovation, teamwork, and service. And let me give you a few examples of how we began to address those. Quality, we're thrilled. The U.S. News and World Report every year reports us in the top 4 or 5 hospitals in the country, but that's not the real measure of quality. We think it's more important that you look at quality in terms of actual metrics. And I've asked each one of the institutes to develop a set of metrics that they use to measure quality. And in cardiac surgery, it's pretty easy. You walk out or you get carried out. It's not so easy to develop metrics for quality in things like dermatology and rheumatology and diabetes. But nonetheless, I've asked them to establish those metrics, to look at them each year. The most important thing we do is we look at our mirror and say, where is the opportunity to improve? And these are available. In fact, if you want to, you can go home tonight and look them up on your internet, as we were trying to be very transparent about these. As far as innovation is concerned, we think that that is vitally important for a progressive organization, particularly one located in Cleveland, Ohio. Our research activity has about 2,200 research projects going on simultaneously. About 1,200 publications come out of that group each year. We have a tech transfer organization for our intellectual capital, which has generated about 340 patents so far and more in the pipeline. That's spun off some 35 companies so far. We did an interesting thing with Lowe's. Lowe's is a large hardware company store across the United States. And we have contracted with them for them to send us all of their cardiac surgery from all over the United States at a special rate. They think that they get high quality this way and predictable cost, and that has been caused a lot of interest across the country with this type of arrangement, and we're currently talking to 15 more companies. Teamwork is really something that has changed enormously in healthcare over time. When I trained, there was a solo practitioner who used to do everything. He could come to your house, diagnose you with a stethoscope and an eye and ear peeker, and then shake out a few pills and be able to take care of any ailment. We now think that healthcare has become much too complicated for that. The total amount of knowledge doubles every 2.5 years, making it impossible for an individual to keep up with all of this and manage your care. So we've organized around teams. This is the original cardiac surgical team at the Cleveland Clinic who did the first coronary bypass operation some 40 years ago. And the teams have grown over time. This is the current cardiac surgical team doing about 4,500 procedures annually. Not only have teams become larger, they've become substantially more sophisticated. Just about 2 years ago now, the first face transplant in the United States was done. And this is the team that did it. 13 different specialties involved in this particular procedure. Plastic surgeons, ENT surgeons, dentists, anesthesiologists, immunologists, etc. They practiced together for 5 years prior to doing this first operation, and each one bringing their particular expertise to the program. And perhaps most importantly is service. We recognize that we are in a service industry. We need to respond to the needs of our patients. And patients, frankly, don't measure anymore the quality of their health care simply on the basis of a clinical outcome. They look at a clinical outcome, they look at the physical experience, and they look at the emotional experience. And we've tried to address all of those. We put together a second CEO, or 2 second CEOs, Chief Experience Officer, to begin to look particularly at the physical experience and the emotional experience of our patients as they journey through the healthcare delivery system. And one is a chief nurse, and the other is Jim Merlino, who is a colorectal surgeon. Patients are greeted at the door, and people in red coats to help them find their way through the maze of the facilities. Art is used as a wayfinder in our hospital, as well as begin to make it more human. We have brought natural light into the, using the architecture, and at the foot of the bed against the wall is a couch which pulls out into a full-time bed so family can stay with the patient. We got tired of patients walking down the hall and thought it was dehumanizing to have one's cheeks flapping in the breeze as one walked down the hall, so we coerced Diane van Furstenberg to help us do a patient gown which wrapped and brought dignity to the hospital experience. We have color-coded the people who work in our hospital, because you can't tell the players without a scorecard. If somebody in a red outfit comes in, you know that they're from lab, or someone in black vest, they're from food services, and we give the patients a key to this color code. We've done away with visiting hours, so the hospital is open to family all the time. We think that they are an important part of the caregiving team. We've opened the medical record so that if you were in the hospital, you'd probably like to know what's in the record, and so we just said, let's open the medical record and make that available to you. It's really your record, not the hospital's record. We've added massage therapy, pet therapy, where dogs come in and visit the pediatrics wards and greet people in the lobby. Our prayer room is open to patients of Muslims across the entire organization. And then we began to think about a healthcare organization in its bigger sense. Is a healthcare organization really about health? And frankly, in 30 years, I had never looked after a healthy patient. And I thought, as I thought about it, I thought it would probably be worthwhile that we try to keep people healthy rather than take care of them once they got sick. So we looked at the causes of premature death in the United States, and 40% of it is due to behavior: obesity, sedentary lifestyle, and smoking. So we began to approach these things. The first thing we did was ban smoking on all of our facilities, on the lawns and the parking garages and the buildings, etc. The next thing we did is we decided to stop hiring smokers. This was a statement that we made because we thought we needed to model what a healthcare organization ought to be. That is now there are 60,000 companies across the United States, 6,000 companies across the United States that don't hire smokers. We reached out into the community and gave them free smoking cessation. This is what's happened. The smoking rate across the United States has stayed fairly steady at about 20%. In Cuyahoga County, over the last 5 years, we've seen the smoking rate go from 28% to 15%. So you can have an influence on the health of the community and subsequently reduce the behavior-induced diseases. We then turned our attention to food that we serve to our patients and to our employees, and took trans fats out of all our foods. In the cafeteria, we put the number of calories on servings of food. We took pop out of the vending machines and replaced it with juices and water. We then, for our patients, for our employees, we started a major program to reduce weight. We gave them free Weight Watchers, free curves, free yoga, and a number of and free access to our fitness centers. I'm pleased to report that we've lost almost 200,000 pounds. You know, you got to start someplace. We're not all Jack and the Beanstalks just yet, but we're headed in that direction. We then took this and began to reach out into the community, and we teamed up with the YMCA, Curves, and the Cleveland Clinic, and we offered Cuyahoga County and the citizens of Cleveland access to the YMCA, and we had 25,000 respondents. And over time, they lost 25,000 pounds in the process. And this was, again, an opportunity to show what you can do if you put your mind to it in terms of a community. In terms of sustainability and being a good corporate citizen, all our buildings are now LEED certified. We've put solar panels on top of several of our buildings. We've reduced our energy use significantly from where it was. And it continues to go down through a number of approaches changing light bulbs across the place, 2, encouraging people to turn the lights and computers off at the end of the day, and begin to decommissioning several buildings that were not environmentally responsible. Our recycling program has gone through our initial goal of 25%, and we're headed hopefully to 50% in the near future. Now, this organization is unique, and it's unique because of our founder and what they suggested that we do. This is George Cryle, who's on the opening of the dedication of the Cleveland Clinic, said our institution is designed to meet what we believe to be a public need for a more flexible organization. We think that we have changed our organization significantly over time and will continue to innovate as we go forward to meet the demands of our community. Let me just finally say how pleased we are to be here in Abu Dhabi, to have an opportunity to introduce our model of care to this community and this region of the world. We are going to be here for as long as you'll have us. We are deeply committed to making this a successful venture and going forward. So thank you for the opportunity to share this with you today, and I'd be delighted to answer any questions.
Specialization of care to limit the facilities which have to do these increasingly difficult operations. What sort of drawbacks do you see to that being implemented in a larger scale across what could, potentially be a nationwide system of healthcare?
Well, that's a great question. Actually, we think that this is a very good thing to do. As healthcare gets more and more complicated, you have to realize that it's called the practice of medicine. And the more you practice at it, the better you get at it, and any doctor will tell you that. And the more efficient that you become in doing that. And to have an arms race where you begin to replicate things in multiple different locations doesn't help the quality and doesn't help the efficiency. And if you look at the healthcare discussion that is going on, not just here and in the United States, it's going on across the world as people see the skyrocketing cost of healthcare. There's really only 2 things that you're going to do to control those costs. One is to make a more efficient delivery system, and that requires doctors to be properly incented, patients to be properly incented, insurance companies to be properly incented, and collaborate. And secondly, you have to reduce the burden of disease through the public health things that I talked about. And I think the proper incentive speaks directly to your question about centers of excellence.
And I'm going to add just a little bit to that. The challenge is huge because you have lots of factors. You have, in Cleveland and probably across the United States, you have a lot of people who love the Cleveland Clinic and will travel. I come from a part of the United States where we have 6 major academic medical centers in a 20-mile region, and we're killing each other to compete, and for patients. So it's clearly works for them. It's not something we could do in New York unless someone said you have to do that, and then what would the fallout of that be? Would the public embrace it? Would the political environment force us to do such a thing? Would the reimbursement systems make it work for everybody to be successful? So it's a really big challenge, and clearly they've led the way in this, but it's going to be regional, and it's going to take a lot of effort and will amongst everybody involved to want to make that work, and the incentives are not aligned.
Yeah, I think you raise a good point, but let me just point out 2 things to you. First of all, 80% of our patients come from Northeast Ohio. 1% come internationally, and the rest from around the United States. But we do have competition there too. With about half a mile away is University Hospital, which likes to try and compete with us. And frankly, I'll tell you, one of the things we're doing now is we're in the process of closing hospitals and reducing the number of beds, because over time what we've seen is hospital stays are shorter. There are 200,000 fewer beds in the United States now than there was 25 years ago. And more procedures are being done as outpatient than inpatient. So care is moving from hospital-centric to outpatient to home care. And this is a huge change in what's going on in the healthcare delivery system.
Okay. Thank you very much for interesting presentations. At Cleveland, do you have problem attracting top quality doctors with the one-year contract system? And then the second question, what's your view on the healthcare debate in the US?
Well, I'm not sure. What was the second question?
Healthcare debate in the US, what's your views?
Yeah.
Oh, what are your views?
First of all, we do not really have too much trouble at attracting doctors with one-year contracts. I've had 35 one-year contracts. Always keep my fingers crossed and be on my best behavior. But we think the important thing about attracting doctors is a couple-fold. First of all, you pay them competitively. So we pay about what the average of an academic physician across the United States is by specialty. But more important than that is, I think, is the culture and the atmosphere in which you allow a physician to practice. Physicians, frankly, want to practice medicine. They don't want to fill out insurance forms. They don't want to spend a lot of time worrying about where their secretary is going to come from. They don't want to worry about the supplies. We look after all that sort of stuff. So doctors practice medicine, and they do it in an atmosphere where they have the tools to do that. So we compete very well. Just for an example, recently, or I should say about 5 years ago, I recruited a cardiac surgeon from Boston who was offered to be chief of cardiac surgery at Harvard for the same amount of money to come to Cleveland. So and by the way, he's going to be coming to Abu Dhabi to be head of cardiac surgery here.
And we have the opposite problem in New York.
So you know, that has not been an issue for us. Now, healthcare reform is an incredibly complicated issue. We were talking here earlier, we got a 3,000-page bill that came out. We recently had 6 pages of that bill talking about accountable care organizations. There are 429 pages that came out to tell us what that was. So this is a very complicated bill that we're dealing with. You know, how it's, and people ask me how I feel about it. As soon as we know what it is, I'll tell you. But, you know, we really don't know what it is. We clearly understand that we have to change from where we are now. But we don't know what this bill is, so I can't tell you the answer to whether we like it or we don't like it or how it's going to affect us.
Yes, my question is for Andrew on your end-of-life care slide. First of all, end-of-life care is a bit depressing in terms of a term to use. I'd rather maybe say senior care or something. You were talking about spending 80% of the money in the last 30 days of their lives. Don't you think there's a conflict between not legalizing assisted suicide and you know, spending the money? After all, it's a benefit-cost analysis when it comes to the technicality. So
I'm glad you asked me that question. One of the things I get to do is, my job is really not to, I can talk to you afterwards and tell you my opinion on that. My job is not to sway an opinion of anybody based on my personal beliefs. My point in that slide, we call it end of life in the US, we can call it anything we want, is just to merely point out the facts. We spend a tremendous amount of money keeping people alive in the United States at the very end. Is that right or wrong? I don't know. Again,
a lot of them do not want to stay alive. So don't you think that maybe there should be some sort of
but if the public
legalization of
absolutely.
suicide?
I mean, well, sure. I mean, there are lots of ways to tackle that, and there'll be thousands of pages of legislation if something like that were ever to be discussed. My point, and it won't be, but my point in raising it is that it's a problem. And in certain parts of the country, the problem is worse. NYU is an example. We partner with Bellevue Hospital, which is the city hospital in New York. The faculty that work at NYU also work at Bellevue and treat the patients there. And Bellevue, as a city hospital, spends significantly less, same doctors, spend significantly less on end-of-life care at Bellevue than they do in their NYU practices. And there are lots of reasons for that. Patient demand, our patients and their families are demanding that we do it. We can go on forever about that. I think it's a fair conversation. Your question's fair. I don't think it's realistically going to happen in the U.S., but it's certainly worth talking about.
Thank you. What would you say are the lessons the UAE can learn from the situation in the U.S.? In other words, what things are going right in the U.S. that the UAE can emulate, and what things are going wrong that the UAE can try to steer clear of?
I'll let you go. You can go first.
Well, I wouldn't for a second pretend that I'm an expert on the UAE's healthcare delivery system. So let me sort of tell you what I think is happening in the United States. I think what we're seeing in the United States is a consolidation of healthcare. I think you're going to see hospitals come together in systems. There are going to be fewer standalone hospitals. And because the complexity of IT and all the back office stuff is not going to permit these hospitals to be financially viable. So you're going to see that change. I think that you're also, and I might add, you're going to see as hospitals come together in systems, they're going to put pressure on purchasing and the producers of products that we buy, and that will drive down cost because the pressure is coming on us. We're going to turn around and put it on everybody that we deal with, which I think is a good thing. The other thing that I'd say is we're going to see increasing use of IT, and the IT is not going to drive down cost. The question is, what's cheaper, an abacus or a hand calculator? Clearly, the abacus is. Clearly, paper and pen is cheaper than a computer. We're just going to change places for the people who drive around the charts, for techs that look after all our IT. But it will drive quality. And in the end, what we hope we'll see, and we don't have proof of this yet, we'll see that the quality reduces the cost in the long pull. So I think, we're seeing two major things happen. There are a lot of other things, but I think, one other really big thing. Last year, for the first time, we saw more physicians employed than were self-employed. In other words, physicians are now lining up to be part of an organization. And I think that goes with the idea of teamwork and having to come together in a major organization to drive something. I think those are all good trends.
I'll throw in one of the things I learned today from talking with people, local healthcare people, is that there's, much like the United States, there's a wide view of how healthcare actually works in the UAE and Abu Dhabi, and from we don't want to do anything like the United States to, well, the United States trains some of the best physicians, and has some of the best facilities in the world. So I think there's a lot to learn, and I think that Abu Dhabi is going about, and the UAE for that matter, is going about it the right way with creating partnerships with the Cleveland Clinic, who, again, I work for NYU, we're a competitor hospital, but they've really pioneered some wonderful programs in this way. So to have them in this country is a wonderful thing. To have NYU Abu Dhabi in here and talking about new education programs, public health policy courses and lectures and programs like this, I think that there's a lot to learn from our country to bring over here, and there's a lot not to do.
Yeah, and I think one of the important things we've done today is we've opened the debate. And you can't talk about something, if you don't talk about something, you can't solve it. And I want to give you the example of AIDS. There was a time when no one could talk about HIV or AIDS. And once we started to talk about it, we began to figure out that this was something that we could deal with and have dealt with it as a society. I think the same has to be said about smoking and obesity and the type of health care you want and end-of-life issues and payment and all of these issues, which are very difficult issues, but clearly have to be part of the public discourse. Because at the end of the day, we are all going to be patients. And this is the one thing that probably affects absolutely everybody, and that's healthcare.
On education, which will contribute enormously to prevention of, for example, prostate cancer, telling people about lycopene, that's cooked tomatoes, I'm wondering about the role of the internet and also the role of education to young children, the role, and continuing education throughout life, and the role of the internet.
Andrew?
Well, listen, I think that obviously those things play a big role. I think the internet has done two things. It's educated people with information that obviously they never had before, but it's also on some and help them self-direct their care to the place where they think they're getting the best care. It's a double-edged sword, though. So they become an educated consumer, which is good, because you'll recall I said there's a big problem in our country because there's a disconnect between the price of what we pay for the health care that we get. So the internet as a tool, learning about the disease state, is very powerful and may help the patient make some better, more cost-effective choice. The problem with that is there's also more information about more treatments, and I can't tell you how many times I hear stories about, well, this doctor said no, so I went to 3 other doctors because I had all this information from the internet and finally found one that was willing to try something that didn't work. So it plays both ways, but clearly it's a role. Listen, the whole world has changed with information. Healthcare is no different.
Yeah, I would second that. And unfortunately, I'm going to have to excuse myself, and Mark Harrison is going to be my body shadow here, my double. And I want to thank you all again for coming tonight and for the opportunity that you've provided for the Cleveland Clinic in Abu Dhabi. Thank you.
Safe travels.
As Toby mentioned, that Cleveland Clinic is a culture which has grown over the period of last 91 years. How are you going to meet UAE's expectations that this system will be here within the next 5 years? Do you think that is achievable, or how are you going to tackle this challenge?
Welcome to Abu Dhabi.
I know. My friend Atul. No, the way we're going to transplant culture is we're going to replicate as much of what Cleveland Clinic is doing well. There's a lot that is that's going quite well back in Northeast Ohio that I think that we can transplant with a fair degree of ease. So anything from our business intelligence systems to the way we do annual professional reviews, to, as you know, a large number of our physician chairs. We actually hope that all of the institute chairs will, in fact, come from Cleveland Clinic, and then a large number of other docs as well. It's actually been gratifying in the last couple of weeks, the number of folks who've come out of the woodwork and expressed tremendous interest in joining the team here. And I think a lot of that credit is due to Dr. Cosgrove, but as well to the good work that's been done by the CCAD team. So I think that it's not going to be easy, but I think that it's going to be quite doable. And in fact, I suspect that CCAD is going to lead Cleveland Clinic back in Ohio in a number of ways. We have some issues that result from lots of years of history, as well as some advantages. And I think that CCAD should prove to be a blank slate in many ways for doing some things better and, in fact, informing the rest of the system. Does that answer your question? You're welcome.
Yes, I have just two questions, and one, if you could just respond as briefly as you can, because the others may not be interested in it as far as this audience. But it seems like your evaluation system that your CEO alluded to seemed to be a very key part of either driving the culture or driving the success of the Cleveland Clinic and making it distinctive from other hospital systems. And I just wondered if you could talk a little bit about how it's distinct from other evaluations, or at least what do you consider distinct about it? And then more of a general question for the NYU colleague also is that, to me, it seems like in the U.S., the problem with healthcare is one that is fee-for-service. So, doctors may not have an incentive to economize because the more they do, the more they're paid. And also the fact that patients don't pay the bill directly. Someone else is paying on their behalf, and so patients will say, just spend as much as you want because I don't care. I'm not paying the bill. And then finally, when you're sick, unlike other services, you don't have time to compare. You don't have time to do shopping. And medicine is so complicated. So consumers can't really do much comparison, or they don't understand the information. So I was wondering that those three issues being challenges, how do you see that? How do you see healthcare being reformed? When I could be wrong, but I think those are the major challenges in reforming healthcare
You
in
want
the
to
U.S.
take the skin in the game question first, or?
Yeah, I mean, I just want to make a comment. Even a sick patient, I can tell you, I can't speak, in case you haven't figured it out, the Cleveland Clinic is special and different, and they'll talk about that. NYU, I think, is special and different too. We have many similar models, and we do some things differently because our market is different, as it would be in any part of the United States, as it would be in any part of the United Arab Emirates. There are market factors that play into how we deliver healthcare. So again, educating the public on the overarching themes is important. But I want to make one comment about a sick patient and information. Now more than ever, going back to the internet question, even our sickest patients are checking us out on the internet, asking their friends. They are choosing their doctors far more carefully than they ever have in the past, even when they're sick. Even when we have all types of patients in New York, as they do in Cleveland, and all different socioeconomic factors play into that, but they're all checking us out. So the patients are engaged as it relates to the disconnect between what they pay and what it costs, and the insurance company's role. You're right. I mean, that's part of it. And the problem is most people don't find themselves in that conundrum of how it works until they're actually engaged in the system not well, and then it's an overwhelming problem. Because even though we have insurance and there's a disconnect between what it costs and what we pay, it still costs a lot of people a lot of money to get their health care, and it becomes very problematic for them when they have hospital balances and co-insurance amounts that they can't really cover. So it's a mess. And in terms of evaluations and one-year contracts, I wish Dr. Cosgrove was here. They have one-year contracts. I wish we could do something like that in New York. It would just, and I have a colleague here with me in the front, and he and I negotiate all the physician contracts. And New York is like a baseball market, and it's really hard. We're competing against a lot of high-quality competitors, and I know Cleveland obviously has competitors too, but it's a real challenge, and we could never sell that.
Well, I'd like to comment just briefly on the second question, and then I'll get to the annual professional review or the APR issue. There is perversity in a fee-for-service sort of environment, and in fact, the freedom from that perversity is one of the things that allows us to attract what I think are the highest caliber physicians anywhere. It's actually incredibly liberating to be able to see a patient and say that you can't do anything more for them, actually. Or it's incredibly liberating to be able to see a patient and refer them to your colleague because you know that they do that procedure or take care of that disease entity a little bit better than you do, and not worry about whether that's going to end up in your paycheck at the end of the year. And that actually ties directly into the APR question. So I know of no other health system in which the staff docs actually get FaceTime with somebody on their board of governors or whatever the highest level of professional activity is in the organization on a yearly basis to discuss their performance and their opinion of the institution's leadership. And what it does, it allows those of us in leadership to have really a direct line to how the people who are touching our patients feel about the organization. And so the things that we prize we do prize productivity, of course. We like people to work hard. But we also prize academic excellence, teaching, administration and leadership, and maybe above all, collegiality. And that collegiality is the piece that allows people to do the right thing for the patient and not worry about whether it affects their compensation. Now, I would actually I haven't practiced in New York, but I would say, boy, that would be a fun stake in the ground to put, to say, You know, we believe so deeply in the physician model and doing the right thing that we're going to pay you a fair salary. We're going to provide you an opportunity to do the right thing for patients, and let's see where the faculty flow.
It would be fun.
It would be, you know,
I may not have a job, but it would be fun.
There's a boy, what's the book about baseball? Pardon me? Moneyball? I think I heard somebody say it. So thanks, Kevin. So the premise of the book is, I think it's about the Oakland A's back in the early 80s. Is that right? And the premise of the book is, here's a team that had a very low budget for recruiting talent, and they went ahead and they won 2 World Series. And the way they recruited, the way they won those 2 World Series is by recruiting a lot of people who are good team players and hit a lot of singles and doubles, and they didn't hit a lot of home runs. And I'd like to think that we have a lot of people who can hit home runs at Cleveland Clinic, but we definitely have a lot of people who can hit singles and doubles and get along with their teammates every day. And that's the competitive advantage. And I think it's good for patients too.
And this also speaks to the challenge that we face in the country. So if you were to try and legislate just this conversation, well, how are physicians employed in the country? You can imagine the challenge that would present, given the numbers, the huge differences in the system that we have for employing them around the country. We have about 1,000 physicians that we employ in our network, and I have literally, what would you say, Josh, 500 different contracts with all of them. It's a remarkably different system. It's not better, it's not worse, it's just different. And our competitors do things similar and different, and Cleveland Clinic does it their way. So to me, it just highlights the challenge we all face in trying to tackle this. Clearly, it's worked well in Cleveland.
The problems with the health cost in the US is the cost of insurance and lawsuits, against lawsuits. Is that still the case and is it being changed?
I can take. You want to go ahead? You probably do a lot with tort reform.
We'll both take a crack at it. It's kind of fun to do it, both of us. Yes, it's a big. There's no one factor that causes healthcare costs to be expensive. It's not insurance that's expensive in the United States. It's healthcare that's expensive in the United States. Insurance is just really the middleman paying the claims for us. It's all our money. It's all expensive. If healthcare were less expensive, insurance would be less expensive. Tort reform is very controversial. The data on whether or not it works is disputed. Texas tried to do things. They passed tort reform, and apparently the cost didn't come out of the system the way they expected. New York just tried to do something in its budget battle that ended up not passing the state legislature, the budget process. From my perspective, I have to believe that tort reform would, meaningful but fair tort reform would in fact lower the cost. It's not the malpractice premiums that are costing us the money, and I assure you, our physician organization spends millions and millions and millions of dollars a year on malpractice claims, and we have a very low experience rating. We have good doctors like they do. But it's the number of tests that we're ordering because our doctors are afraid of being sued. You can't really quantify that. You can do a lot of research on it. You'll never really know. But I gotta believe, as someone who works in the system, it's worth trying. And unfortunately, healthcare reform did not include that. It included about $50 million for a pilot program. And I think that was a big mistake, because I think they need to do more work in this area.
So I'm not a lawyer. I'm a pediatric intensivist. We are a self-insured organization, like many academic medical centers in the United States, and we have a captive in the Caymans. Now, I've lobbied to get on that committee and get to go down there, but I've failed again. So now I'm here in Abu Dhabi to enjoy the sun and the sand. We actually have experienced dramatic decreases in our costs of medical malpractice insurance, at least associated with tort reform. Now, I also think that it's associated with something that's much more important that we've done, and many of the major academic medical centers have done, and that's that we own mistakes much earlier than we did. So as somebody who takes care of very, very sick patients, and actually as a person who has made a couple of mistakes and actually harmed a couple of patients, There's nothing more horrible that a person who gets up in the morning can do, to take good care of people can do than to be associated with a bad outcome for them that was preventable. It tears at your soul. So what we've done is we have taken some of the evidence from around the country, and we have early disclosure, and we actually encourage our physicians to talk with families and tell them when an error has been made. This is a very different approach than was taken in the past, in which when a mistake was made, families could expect that communication with the medical team would be greatly impaired or almost shut off. That's wrong for the patient, it's wrong for the family, and it feels terrible for the provider. So I'd like to think at least some of our savings in terms of medical legal expenses are related to doing the right thing, which is to tell people when you've made an error.
Thank you very much for the interesting speech that you had. We kept on saying the challenges and so on and so forth. What are the challenges you are anticipating while implementing Cleveland Clinic model in Abu Dhabi? I hope it's not a very
No, that's I've been here for, as I said, for 23 hours. I think that I would like to take a stab at that, though. Atul, he alluded to the fact that we have a lot of history at Cleveland Clinic, that I think it becomes a self-perpetuating culture based on critical mass. We don't have that here yet. Yet we have another challenge and another opportunity. We anticipate there will be as many as 60 nationalities represented at Cleveland Clinic Abu Dhabi. That means that people are coming from all over the world to provide great care for patients and to learn a culture and to work together as a team. We also anticipate that there will probably be, based on the fact that people have come from a long distance, there will probably be higher than the 4% turnover annually that we experience at Cleveland Clinic. So I think that building a sense of culture and a somewhat more transient, although we hope not very transient, team, as well as people coming from a diversity of backgrounds could be a challenge. The way we'll approach that is by developing as much standard work and standard expectations as possible. So I hope that there will be a Cleveland Clinic approach to mechanical ventilation. Hope there will be a Cleveland Clinic Abu Dhabi approach to dialysis, to preparing a patient for the operating room, for seeing somebody in the emergency department, and that will allow people to come from many different environments and to, as seamlessly as possible, fit into the culture. And then finally, I'm a strong believer in continuous improvement. At the main campus, I had a team of 50 engineers who worked for me, constantly refining our operating model. Although we won't have that many people here, I anticipate that continuous improvement will be a big part of how we take care of people, and I think that builds teamwork as well.
I have heard suggestions that the U.S. healthcare system is subsidizing the rest of the world because the most expensive treatments and drugs can be used. Do you agree? What's your opinion on this?
I'll go on this first, because this one I write about it a lot. Yes, we do. Yes, the United States does, and let me give you an example, because it came up in the healthcare reform debate in the United States, where everybody was saying, well, Switzerland does such a fantastic job for providing healthcare to their citizens with a private-public model, just like the United States. Why can't the U.S. do it and cover its costs? Well, one peels back the layers on Switzerland. So this is a perfect example of how it works. Device manufacturers will come up with a defibrillator that shocks the heart. I'm not a doctor, so I don't always get these things right, but you get the idea. Shocks the heart back into working when something goes wrong. And that defibrillator in the United States goes for about $25,000. That's what Medicare will pay the hospital. And these numbers are ballpark numbers. And the device manufacturer sells it to us for $23,000. So we'll make a little bit of money on the device to cover our costs, pay our nurses, keep the lights and power on in the hospital. If you want to sell that device in Switzerland, the Swiss government has said, we will not allow you to sell it in this country unless you sell it to us for $17,000. So in fact, and ditto on pharmaceuticals and other things. So and they regulate the number of prescriptions that doctors can write. They actually review the number of prescriptions written and benchmark them against others. So they've taken a very aggressive, this is just one example, approach at looking at controlling costs artificially. So what happens to those device manufacturers that are all based in the United States? Well, the largest market for these devices is in the United States, so they just raise the price. They still have to make money. It's a public company. They have shareholders. They need to invest in new devices. So what do? They charge the US market more because it's not regulated. So yes, in many ways, we do subsidize the world. A lot of research is done in the United States that gets transported around the world. I once read a study that 80% of the global research dollars spent on all healthcare delivery research has some component or origin in the United States and then gets exported to other countries. So it may, the final piece of it may be done in Abu Dhabi, but there's some connection back to the US. And it's very expensive to do those things. And the US market is the market that pays for it.